Hey, good afternoon, everyone. I'd like to, well, to maybe just wait one more minute to let everybody join the webinar today. Just turn in 3 o'clock now. Okay, we'll go ahead and start. Um, I'd like to welcome and thank everyone for joining us today. Today's webinar, Blenderized Tube Feedings, Best Practices, Challenges, and Decision Support Tools, will be presented by Theresa Cividin, registered dietitian and regional professional practice lead for dietetics at Vancouver Coastal, and Lisa Vardi, registered dietitian at the ALS Center at GF Strong Rehabilitation Center in Vancouver. I am Erin Bailey, a medical affairs manager with Nestle Health Science, and I'm your moderator for the webinar today. The format of today's webinar will consist of two presentations followed by a blenderized tube feeding recipe demonstration. At the end of the webinar, there will be time for questions, so please enter your questions into the Q&A box, which is located to the right of your screen. We will also have polls throughout the presentation today, and you can access the polls to the right of your screen just under the Q&A box. Also, I wanted to let everyone know that once the recording is ready, a link to the recording and slides will be emailed out to participants. We respectively acknowledge that Nestle offices across Turtle Island are located on the traditional treaty and unceded territories of First Nations, Inuit, and Métis people. Indigenous people share a sacred relationship with the land, and this acknowledgement is only the first step in learning more about our history and taking action towards reconciliation. I would like to now introduce our speakers. Theresa is a highly experienced registered dietitian with over 25 years of clinical practice in diverse areas. She has extensive experience in developing practice guidelines and decision support tools to help guide dietitian practice. Our second presenter, Lisa, has experience in diverse inpatient and outpatient settings. Lisa has spent the last 6 years at the GF Strong Rehabilitation Center in Vancouver, focusing on home enteral nutrition with a particular interest in home blenderized tube feedings. We are very excited to have Theresa and Lisa leading this webinar today, and I'll now turn it over to Theresa, who will be presenting on the development and implementation of a decision support tool for blenderized tube feeding.
Thank you, Erin, for that introduction. I would like to start off my session, my part of the session in a good way by honoring the land that I'm presenting from today. So I'm presenting from the traditional, historical, and unceded territories of the Coast Salish people of the Musqueam, Squamish, and Tsleil-Waututh nations. I am especially grateful to have the opportunity to live and work on these lands, and I'm grateful to the Indigenous people who've nurtured and cared for the lands and waters around us so that we can be here today to experience all that the lands have to offer. I will be describing the process we undertook in developing a decision support tool for the use of blended tube feeds at Vancouver Coastal Health. The process actually took about 4 years from start to finish. So it wasn't a quick process. We actually started discussions about development of a decision support tool in the summer of 2017. The idea was initially brought forward to me by dietitians working at Vancouver General Hospital who had an interest in using blended food for tube feeding. They were reporting that patients were starting to ask about using whole foods and blended foods in place of formula for their tube feeds, and were asking how this could be accommodated at Vancouver Coastal Health. It took about 3 years to actually have a draft ready for circulation, which went out for review and feedback, and then the guideline was finalized and endorsed in October of 2021. I'd like to, before I get into the presentation, we just have a quick poll question for you. So you should be able to access the poll by the poll button on the right-hand side of your screen. So if you can just let us know if you have you implemented a decision support tool for blenderized tube feeding management in your practice, and just indicating A, B, C, or D, so we can get an idea of who's in the audience here with us today. So I'll give you a chance to answer that poll. So I'm hoping everyone has access to the poll and is able to respond. Okay, so I see some of the answers coming up here. I see that yeah, about 11% have actually developed, have implemented a tool, and a few more considering implementing one. Okay, but the majority of you haven't. So hopefully we will be able to, you'll be able to learn from sharing of our experiences with developing this tool. So thank you for answering that. So in terms of the actual development process, the first step in the process is actually recognizing or identifying that there is a need. And this need was actually identified to us on 3 levels. So we were, as I mentioned, hearing through dietitians, from patients and clients, that they were asking for this. They wanted to consider using blended food for tube feeding and basically wanted an option from the commercial formulas that were available. The second level we were hearing from was dietitians who were getting these requests from patients. They were actually reporting a lack of confidence with managing blended food for tube feeding. And as well, there was a lack of published guidelines or standards available at the time. We actually had one of our dietitians, Claire Correa, who did a research project surveying dietitians in BC to find out about their perceptions on education, confidence, skills that they needed. And the vast majority of the respondents who responded to the survey were reporting this lack of confidence. It wasn't something that was covered in their academic preparation. And as I mentioned, it's just a lack of published guidelines or standards out there. And then from an organizational level, we actually had no guidelines or policies to support these patient requests. We didn't have direction for nursing staff, food service staff, or dietitian staff. So it was identified that there really was a need for this guideline. So once we'd recognized the need, our second step in the process was gaining leadership support and obtaining the support early on in the process. So before we actually started the guideline development, I met with the professional practice directors for both nursing and allied health to ensure that we had their support in terms of implementing this practice within Vancouver Coastal Health and developing the guideline. I presented it in such a way that showed how it aligned with the organizational values at Vancouver Coastal Health, being that we care for everyone, so caring for our patients and supporting them in their choices. We're always learning. This was an emerging area of practice where there, as I mentioned, there wasn't a lot of published guidelines or literature to support the practice. And then lastly, we strive for better results. So having fulsome guidelines in place to support our staff, we can help to ensure that we are providing evidence-based care and best practice. So it was helpful to get that support early on. It was helpful in terms of them helping me to make connections with groups that we needed to collaborate with within the organization and outside of the organization, such as regulatory colleges and our risk management, legal, and ethics department. And by ensuring we had their support, it just allowed for a smoother process for approval and endorsements down the road. So once we had our leadership, had the support of the leadership team, our next step was forming the development team or the working group that was actually going to be developing the guideline. So that involved recruiting champions and subject matter experts. And luckily, as I mentioned, we had a group of dietitians who had a keen interest in learning more about use of blended foods for tube feeds, and some of who had been practicing in this area as well. We also wanted to recruit nursing reps on our development team because the guideline was going to focus around dietitian practice as well as some nursing practice and guidance. We also felt it was important to have representation from all of the areas of practice within Vancouver Coastal Health. So we had dietitian and nursing reps from acute care, long-term care sites, community and home health settings, as well as representatives from both the urban and the rural sites within our health authority. We started off with weekly meetings to keep the momentum going. And as we progressed over the years, it went to monthly and then quarterly meetings. Once we had our development team and we were actually starting the guideline development, we were taking a systematic approach with this. We wanted to ensure that it would be evidence-based. So we did a fulsome literature review to ensure that we had evidence to support our recommendations and our guidance. So ensuring that we had evidence to support it was appropriate for the various populations within the acute care setting and long-term care setting. We had evidence to support recommendations for things such as the appropriate tube size, administration methods, consistency of the blended formula, to minimize tube occlusions, and that we had the support and evidence to support this. We also kept the goal of supporting patient choice at the forefront of all of our discussions, and that was kind of at the back of our mind as we were working through all processes, or through the development process. So one, ensuring we were meeting nutrition needs, of course, but also having the guidelines developed in such a way that it allowed for a flexible approach for patient care. So we didn't want it structured that it was an all or nothing, either all blended food as a sole source of nutrition, but just even having ways to incorporate some blended food to augment the formula that some patients were choosing to use. Our guideline also was structured to address potential barriers and mitigate any risks that were brought forward, such as patient safety, food safety, and then providing the fulsome guidance and direction. And this is where collaboration came in, and collaboration really was key in the development process. As I mentioned, I had the support from nursing professional practice from the outset, and they were helpful in terms of connecting us with the Regulatory College for the nursing professionals in BC. There were concerns brought forward from a liability and risk concern as well about RNs in a care facility or acute care facility administering a tube feed formula that with potentially unknown contents. And what were the risks with this? Was it okay from a regulatory standpoint? We were able to confirm with the college that nurses were able to do this as long as we had a physician order. So that was one big collaboration and discussion that we had. We also collaborated with the patient quality and ethics department around the supporting patient choice, making sure we were doing that appropriately, covering off informed consent, making sure that it was informed. Risks and benefits were discussed with the patient and family before making this decision. We also collaborated extensively with risk management and legal to ensure that any liability issues were addressed in our guidelines, as well as guidance around the need for a risk waiver. This is something that came up numerous times over the years. Did we need to have a documented risk waiver, or could we just have fulsome documentation in the patient's medical chart? We also met with food services to be clear that everyone was aware of what operational limitations may be in place from a food service point of view, in terms of what could be prepared in-house for blended food formulas, versus what was available on a blenderized meal tray. So although we aren't able to provide or make a homemade blended formula in hospital, we do have a blenderized diet available, and there are some pureed food items and blenderized items that are available and could be used for tube feeding. And lastly, we collaborated with environmental health around food safety concerns. And this was particularly a concern for the long-term care settings where there are licensing requirements. So by collaborating with all of these groups ahead of time and during the process, we were able to kind of mitigate and address any potential risks or barriers that were brought forward. In terms of the structure of the decision support tool, we took the approach of dividing it into two main components and being clear whose responsibility it was for what activities around the use of or the decisions around using blended food for tube feeding. So we articulated what the dietitian responsibilities were. The dietitians being kind of the lead in the team collaboration, communicating with the patients and their family and getting the informed consent, patient and family education, of course, doing the nutrition analysis and assessing the nutrition needs were being met. And then the documentation piece, as well as monitoring and evaluation. The nursing responsibilities were structured more around the administration of the blended formula, where it would be stored on the unit, and then documentation and monitoring from a nursing perspective. We also had sections for acute care versus long-term care and community home health, acknowledging that there were different approaches would need to be taken in an acute care setting, different limitations compared to a long-term care home, which is somebody's home. And then the community home health setting where it is actually in the patient's or client's own home. So once we had our decision support tool or guidelines developed, they'd gone through the review process and were endorsed, we were at the stage of implementation. And in order to successfully implement a new guideline, firstly, it needs to be accessible. So we had our guideline posted on our intranet site where all of our guidelines and policies are posted. So it was accessible to all staff within the organization. But you can't stop there. It can't just be made accessible. We needed to make people aware that the document existed. So we had an email distribution with practice update and announcements, letting people know that the document had been developed and was posted for use. We also did education, dietitian-specific education, as well as nursing education. So dietitians and nurses were not only aware of the guideline, but had education on how to use it. And then lastly, kind of alongside the guideline development, we were also developing at the same time patient and client education materials. So these were available at the time when the guideline was finalized to help support not only the dietitians in terms of guiding their discussions with the clients, but also resources that clients and patients could use in terms of recipe development and guidance in terms of decision making around choosing blended food for tube feeding. So in summary, the key points of developing a decision support tool is one, identifying the need. So addressing an identified need, obtaining that leadership support. That's just going to make the whole process go that much more smoother when you know you have kind of that high level leadership support. Forming the working group and ensuring that you do have those subject matter experts as well as champions. Frontline staff are key in providing this expertise as well as being a champion amongst their peers and the healthcare team. Collaborating frequently and throughout the process, the collaboration really was key. And that also helps in going that much more smoothly when you have that collaboration process throughout. And then at the stage of implementing and making sure everyone's aware and the education piece. So it's, as I mentioned, it took 4 years to get from the identifying need to the education piece, but it's a useful resource and is very helpful now that we have this tool available. So I am now going to turn it over to Lisa. We will, as Erin mentioned, do questions at the end. So I'll turn it over to Lisa for her part of the presentation.
Great, thank you for the presentation, Theresa, and thanks for the introduction. Before I get started with my presentation, I would again like to acknowledge that I'm presenting from the traditional, historical, and unceded territories of the Coast Salish people of the Musqueam, Squamish, and Tsleil-Waututh nations. So as clinicians, we stress the importance of evidence-based practice recommendations to provide guidance for us in our practice. However, currently there is very little published professional standards for us to use in blenderized tube feeding for tube-fed patients in the adult population. So the goal of this session is really to provide practical recommendations to ensure best patient practice outcomes and to minimize the risk. So what is blenderized tube feeding? For me, I've defined that as blended food and or fluid, really in any amount that is prepared in a home or a hospital blender, and it's administered through a feeding tube. So if it's made at home, I define that as home blenderized tube feeding. Whereas if it's a commercially made blended tube feed formula, I would identify that as commercially made blenderized tube feed. So really before the 1970s, blending food and liquids and putting it through a feeding tube was kind of the norm. That's what we did for most enterally fed patients. However, after the introduction of commercially prepared formula, homemade formula kind of fell out of favor, and particularly as more and more options became available and specialized formulas came available, blenderized tube feeds kind of fell to the side. However, we're kind of having a full circle moment over the last few years because we're shifting back towards a more whole foods, more natural diet, which has subsequently led to an increased use in blenderized tube feeding again. Okay, so before I get into the meat of the presentation, I have a poll question here. So again, you can click on the poll tab on the right-hand side to answer. So how frequently do you recommend blenderized tube feeding as part of a patient's nutrition care plan? So you can pick A, B, C, D, or E. So I'll give you a moment to do that. Okay, so it looks like the majority of our viewers rarely or never use home blenderized tube feeds as part of their patient care. Just under 30% is occasionally, so 1 to 5 times per year. And then we have about 5% doing it a little bit more often, so 6 to 11 times a year, again 5% one time per month, and just under 3% doing it more than once a month. So hopefully you'll be able to get some practical tips out of this presentation. So what I'm going to do during this presentation is go through the advantages and disadvantages of home blenderized tube feeding. then look a little bit about the clinical hesitation that Theresa touched on in her presentation. And I'm going to go through the risk-benefit analysis that I like to do for my patients. And then we'll get into the sort of meat or the nitty-gritty of a step-wise initiation, preparation, and monitoring of home blenderized tube feeds. So to give you a little bit of background, for the last 6.5 years, I've been working at the ALS Center. So we see clients as an outpatient clinic for anybody in BC or the Yukon who is diagnosed with ALS or PLS. So we have a good portion of our clients who are enterally fed, whether that's partially or fully, and a lot of them opt to do blenderized tube feeds. So this is something that I'm seeing on a regular basis, at least once a week. And so it's been sort of a collection over the last 6 or so years of looking through what guidelines we do have and what evidence we do have, and working with that to create a bit of a system that seems to work well for my patient population. Okay, so first of all, let's take a look at the potential advantages. So for somebody who's on a restricted diet, that might be someone who has food allergies or are on a specific diet for medical reasons, you may be able to tailor their blenderized tube feeds to meet those needs. Again, if somebody has food preferences, diet preferences, or culturally or religiously appropriate foods, those can be incorporated into their blends. Another potential advantage is the social aspect. So food is not just for nutrition. A lot of it is for including in social aspects of eating and providing that nurturing experience for clients, for themselves, or as a caregiver to those clients. Food diversity is another advantage. So we know in commercial formula, we know exactly what we're getting, but we are getting the same ingredients every single time. With blending your own formula, you really get that ability to include a more diverse range of foods. Now, there's a potential lower cost. Again, it really depends on what you're comparing, but comparing a standard commercial formula to a standard blenderized tube feed that I see on a regular basis, you can certainly save money doing it that way. And then there's a potential for improved GI outcomes. So improved reflux, gagging, retching, bowel regularity, bowel adaptation, and improved gut microbiome are all great potentials. And of course, with any potential advantages, there's also potential disadvantages. So one, I think a lot of the dietitians have in the back of their mind is the variability of nutritional composition of the blend. We don't always know exactly what's going to be in a blend, and it could vary from day to day. There's certainly an increase in preparation time and a decrease in hang time. So I'll get into that in a little bit more detail. There's a potential for microbial contamination and an increase in clinician time. So the time that the dietitian is using to prepare somebody and teach them to blend, and then as well to monitor on an ongoing basis. There is certainly a lot more difficulty in making the blend nutrient dense or having a low volume, especially for those who need it for medical reasons. Then you may work or have a client at a facility or a hospital whose policies just don't support home blenderized tube feeds. There are those one-off days like traveling or emergencies where it may be a little bit more difficult to have your blenderized tube feed with you. And then there's always that potential for tube occlusions or tube wear and tear. And again, I'll go into all of those in a little bit more detail later on. So let's take a look at the clinical hesitation. So, I mean, I think some of these things will be on your mind. They've certainly been on my mind in the past. But when a client is considering blenderized tube feed, it's the dietitian's responsibility to provide them with all of the information that they need so that they can make an informed decision. So as we know, information is really easily accessible online now on social media, but the research is still quite limited. So we kind of need to turn to each other and our experiences to improve our skills and our confidence. But of course, there's still lots of questions around things that I've already touched on, like tube occlusions, the nutrient adequacy of blends, and potentially the microbial contamination of blends. So before initiating Blenderized tube feeds, it's important to consider the patient's entire clinical picture and compare the risk of the situation versus the benefit of it. So these are the things that I'm looking at when I look at every individual client, and every client is going to have a different situation. And none of these are absolute. Again, you're going to take a look and you're going to weigh the risk versus the benefit. And of course, that needs to be done with the patient as well. So ideally, you want your client to be medically stable. It's great if they do have a G-tube, but again, jejunal feedings are not necessarily encouraged in the literature because of the limited hang time of Blenderized tube feeds and the implications associated with a tube occlusion and that difficulty in replacing a J-tube. But again, J-tubes are used in Blenderized tube feeds. You want a mature and well-maintained stoma site. So for some people, the average is about 6 weeks up to about 3 months. The literature really supports 14 French tube size or larger. However, if you think about a 60 cc syringe, the tip of it is about a 12 French. So there is reason, or there can be situations where a smaller tube size is used, and certainly you see smaller tubes in the pediatric population. So again, it's not an absolute rule. So some resources suggest patients should be stable on a home enteral nutrition regimen before initiating a Blenderized tube feed, and then to transition slowly, especially if the client has not eaten by mouth in a long time. But again, it really is patient dependent. So ideally, they're already tolerating a commercial formula, they're on bolus feeds, but again, everyone is individual. And then besides the clinical picture, you want to kind of expand outwards a little bit and look at the client themselves. So what is their lifestyle like? What is their ability like, or their caregiver's ability like to prepare Blenderized tube feeding on an ongoing basis? Is it sustainable for them? Do they have access to the necessary equipment and food storage? And do they have access to clinicians who have the ability and capacity to support Blenderized tube feeds and follow up as much as they need to? And then access to hospitals or care if the tube were ever to be blocked, or if they would needed to be replaced. And I've just called out these last three. Again, just extra caution, but no absolutes here. If somebody's on a continuous feed, it doesn't mean that they can't have a Blenderized tube feeds. We do know that feeds require less than a 2-hour hang time. So the bag would just have to be refreshed every 2 hours. And is that increased workload going to be worth it to that client? Maybe yes, maybe no. Specialty formulas, if fluid restrictions or volume intolerances are present, or if they're requiring elemental formulas or an ultra high protein formula, those are all things to consider whether or not that can be managed on an ongoing basis with Blenderized tube feeds. And then there's always that note about increased risk of foodborne illnesses in immunocompromised patients. And that would have to be a discussion between the dietitian and the care team and the client. Okay, before we jump into the steps of blending your own, we have a poll question. So again, if you don't mind making a selection on your right-hand side, what is the biggest challenge you face when it comes to safe preparation practices for Blenderized tube feedings? So I'll give you a moment to answer. Okay, so it looks like we have about 50% the biggest challenge is determining the appropriate nutrient composition. And then about 22% ensuring proper hygiene and sanitation. Okay, so that's good for me to know. I'm going to break down some of those challenges as we go through the presentation. So hopefully that'll address a couple of these concerns. So this is really a practical guide. There's no set way to prescribe or to teach home blenderized tube feeds. So this is kind of just how I do it, and this is how I have figured out has worked really well with my patient population. So initiation, we need to take a look at the macronutrient needs. It's really the same as any other tube feed calculation. It's based on the client and their medical situation and medical needs. So it's really no different whether you're using commercial or home prepared blends. And then you initially want to aim for 1-to-1 calorie replacement when switching from commercial formula to homemade formula. And then after that, following up closely, as some research suggests clients may need more calories when making their own blenderized tube feeds versus commercial formula. But as we know, these calculations are estimates anyways, so we would be looking to follow up closely afterwards either way. So I want to expand a little bit on the fluids. So the way that I estimate fluids is I base it on the total volume in a blend. So the blend can incorporate potentially commercial formula, it could be meat, it could be vegetables, it could be milk, it could be grains, it could be water. Any of those things, I'm calculating the total volume, and I'm going to times that by about 0.7 to about 0.75. And that's really based on the assumption that most infant foods contain about 75% free water. And then I'll determine the additional free water as a difference between the estimated daily fluid requirements that I calculated in the previous slide, and then and finding out the difference between the amount of free water in the blend that I've made. So I find that that's the easiest way for me to make an estimation, and then of course assessing their hydration status after that, as these are all estimates. And something that I do really want to emphasize is that we need to optimize hydration before starting that transition to blenderized tube feeds, because we want to minimize the risk of dehydration and constipation. It can really complicate things when trying to assess if somebody is tolerating their blend, if they start from a place where they're dehydrated and constipated. Okay, so now we'll take a look at the micronutrient needs. So I find that as dietitians, we tend to want to be highly calculated. However, that's not necessarily realistic for clients who eat orally outside of a controlled environment like the hospital or a care home. And that's assuming that no outside food is brought in. But we can't really let that stop us from supporting clients who want to pursue this way of feeding themselves. So as I mentioned, I work with clients who are free living in the community. They're doing what they want. They're eating and drinking what they want. And so I keep that in the back of my mind once we move into blenderized tube feeding. So we can control what we can, and otherwise we need to just be practical about it. So I've called out a few micronutrients here. Others might be appropriate in case-specific situations. So some things we want to just make sure that we have in most blends is some essential fatty acids. So I've given some examples on the slide of sources of essential fatty acids. Sodium and potassium is another one that sometimes accidentally gets left out of a blend. An easy way to get your sodium in is just to do a pinch of salt into your blends, or adding pre-made sauces or seasonings to your blends. So for example, putting barbecue sauce on tofu before you put it in the blender. That's already going to get you some of the sodium that your clients need. And then vitamin D is really that only one that I specifically look at just as a general comment, because most of us cannot get sufficient amounts of vitamin D in our diet, regardless of whether they're eating orally or if they're making their own blends. So that may need to be supplemented. Okay, so we're preparing to transition. You really want to take it slow. So if patients are stable and the patient or their caregivers are motivated, the standard transition that I usually do is replacing one commercial feed with one blenderized feed per day, and then increasing slowly every 1 to 4 days by one extra meal a day until the goal of having all of their feeds blended. You may want to go slower, incorporating one food at a time, specifically if patients are a little bit nervous or if they have significant intolerances. And again, you want to consider the individual. Do they have previous food exposure? Do they have a history of allergies, other medical considerations? And then you want to monitor. So temporary discomfort, gas, bloating, I don't worry so much about if it doesn't last longer than a few days. And again, you have to ensure that the fluids are being met during this time. Okay, so this is kind of the fun part. You get to choose your method. So these are the 3 methods that I use, and I work with my clients to decide what's going to work best for them. So your first option is using like a Canada's Food Guide or My Plate in the US. And it really looks at daily intake of different food groups and making sure you're meeting the right servings of different food groups over the course of 24 hours. Then you can look at blending a family meal. So you would make your plate according to Canada's Food Guide, just as you normally would fill your plate if you were eating orally, and then taking that dish, putting it in a blender with liquid, blending it up, and administering it. And then there's recipe templates. So recipes sometimes have calories or volumes listed, sometimes calorie density, just like formula. So that might be an easy way to step into home blenderized tube feed if you're just getting started. And recipes you can find as a 24-hour recipe. So administering that recipe several times throughout the day until the whole blend is gone. You could do recipes per meal. Or you can make a base recipe where you batch, prepare, and then freeze into individual portions. And then daily, as you take out the blends, you blend in daily additions. So extra veggies, extra fat, extra fiber, whatever it is to complete the recipe. So there's lots of different options, and usually you can find something to suit your client's needs. Okay, so this step is to look at the equipment. Again, these are things that I have come across and I've sort of found what I prefer when blending, either myself or talking through the steps with clients. You need a blender. A high grade blender or a regular home or stick blender will work. And I'm going to break that down a little bit more in a couple slides. Having a sieve, like a fine mesh sieve or a flour sifter, a measuring set, or potentially a food scale depending on what recipe you're using and how the measurements are set up. You need a spatula, some storage containers, so anything airtight will work as long as it fits into your fridge or freezer comfortably. So for some people that might be mason jars or deli containers or silicone ice cube trays. You need access to clean water, clean food, fridge, freezer, and then administration sets. So again, you have to look at the individual and see what kinds of administration sets are going to work for them. If you're looking at a bolus feeds, there are different types of syringes. We have the standard catheter tip syringe, but you may want to consider trying something like an O-ring syringe, which I find tends to push a little bit smoother and sometimes will last a little bit longer depending on how it's cared for. Or there's reusable pouches. So there's something called a Bowley bag. I'm sure there's other ones out there where it's essentially a squeeze bag that you can squeeze the feed into the feeding tube instead of using a syringe to push. If you're going for something like a gravity bag, you want to take a look into large bore gravity bags. In my experience, that tends to run a little bit smoother. And if you already use a pump, you just want to make sure that the manufacturer, if you're borrowing a pump, that there isn't any sort of warning from the manufacturer stating specifically that this pump can't be used with anything besides commercial formula. And then the last piece is if you do have a low profile feeding tube, you might want to consider using a straight bolus extension instead of a right angle extension. Sometimes that reduces your clogging risk. So this table, again, I've sort of collected over the years some food tips to make things easier to blend and some foods to use with caution. Again, there's really no absolute rules here, but I've broken them down into food groups. So for example, grains, cooking grains properly according to package directions. So overcooking really, if anything, versus undercooking, so that when you blend it, it doesn't absorb all of the liquid and make it a stiff blend. Whereas you want to really use caution with refined grains like muffins, white pasta, white rice, as they can tend to gum up the blend. Fruits and veggies, choose different colors, different types, steamed, soft cooked, or thawed from frozen. Those are all good choices. And then a bit of a caution to use with stringier vegetables or fruits with lots of seeds in it, especially if you don't have a high-powered blender. And then meat and alternatives, moist cooking methods are going to help. Smooth nut butters, legumes and tofus, those are all good choices. Whereas you do want to be a little bit cautious with tough meats. Sesame seeds, poppy seeds, unless maybe you throw them into a coffee grinder or to grind them some other way beforehand so that you don't have lots of bits and pieces at the end of your blend. And the last few food groups here, so milk and alternatives, softer cheeses, fortified plant beverages, milk, yogurt, those are all great to blend. Harder cheeses are a little bit harder to blend. Fats, you want to make sure that you're getting those essential fatty acids in, but other than that, it's a great way to add density to your blend without increasing a lot of volume. Liquids, so the liquids are to be added to the blends to achieve the appropriate consistency. I don't find oil to be a particularly good liquid to blend to thin out a recipe. Going for a calorie-containing liquid is probably more appropriate. But also think about liquids. If you're needing to add extra sodium, you could go for like a broth or a tomato juice versus the calorie-containing beverages. So it really depends on what you need. And then we have our other section. So if you're depending what you're needing, if you're needing extra calories, maybe a sweetener is a good option. Needing extra sodium, maybe sauces are a good option. And then there's also those things like herbs and spices, which are really nice as sort of that social aspect or nourishing the client from a caregiver perspective, as well as those non-nutritive components of herbs and spices. So those are all things to consider. So general food safety principles are very important, especially if a patient has a compromised immune system. But as with any food preparation, you're just doing the essentials. You're washing your hands, washing your produce, picking through your dried legumes, making sure there's no pebbles, no debris, washing your equipment properly, storing packaged items appropriately, using the produce before the best before dates. So all of those things are just basic food safety principles, and I won't go into too more detail, but you can always check out the Health Canada website for all of that information. And so once you pick your method, you might want to consider having convenience foods that fit in with that method. So having things on hand is really helpful, especially if you're time crunched that day and you can't get in a full meal, just like anybody else. So having pre-made purees or baby food, shelf staple items like canned soups, canned beans, nut butters, canned fruits and veggies, frozen fruits and veggies. Some frozen edamame you can eat without cooking, or else it's a quick cook. Tofus that are already sitting in the fridge, canned fish. So there's lots of different options. And then you also have the option for commercial blenderized tube feeds to have in your pantry just in case. Okay, so finally it's time to blend after all of that preparation. So you want to pick your blender. As I mentioned before, you can kind of use any blender, but it does come with its potential benefits and disadvantages. So a high-powered blender will enable a greater variety of foods to be blended. So you can do raw veggies, you can do nuts, you can do seeds. However, it might not be financially feasible for a client. And then you also want to consider that some high-powered blenders, unless they have different attachments, may not be able to do small volumes. So that may not initially be helpful if you've got a younger client or someone who's just being partially tube fed with blenderized tube feeds. It may just not be the appropriate size. If you're using a hand blender or just a regular home blender, you might want to lean towards those softer cooked foods, pureed items like yogurts, but you may not be able to do all of those difficult to break down foods. And then you want to ensure that you have a sieve afterwards to make sure you're getting out all those lumps and chunks and seeds. And just to note, so for preparing your foods, you just want to be able to prepare your foods in the way that you would eat them orally. So if meats need to be cooked, you cook your meat. If brown rice needs to be cooked, you're still going to cook it. But things that can be eaten raw, like carrots, you may still throw into your blender depending on your recipe. But generally speaking, you want foods to be cut up into chunks, placed in the blender along with enough liquid, and then blend until a smooth consistency. So blending, there is sort of a range of recommendations as to how long you want to blend for. I recommend blending between 1 and 6 minutes, and you really want to get to that consistency of about applesauce or thinner, depending on how you're going to administer. So what I usually start with is 1 cup of solid to 1 cup of liquid, and then add liquids as needed. So as I mentioned, if you're blending for 1 minute, that might just be pureed foods already that you're just blending up together, applesauce and yogurt. 1 minute and you're good to go. If you're doing a complete recipe with all different kinds of textures in it, you're probably going to want to blend it closer to 6 minutes to get a smooth consistency. So just another note about texture. So it really depends on the size of the feeding tube and the administration set. So it could vary from slightly thick to moderately thick for a pump, but it could get much thicker for a syringe or a reusable bolus bag. So if you're looking for like a pump or a gravity type texture, you're going to go for something like a drinkable yogurt. If it's too thick, the pump will not necessarily deliver accurate volume, so you want to consider that. It can be as thick as something like applesauce, though, if you're doing a bolus feed. And a super easy way to find out if it's the right consistency is just drawing up a 60 cc syringe of the blend. If it gets drawn up easily, then you're probably good to go. Okay, so again, with storage and warming, I'm not going to go into too much detail today, but the general rules are blend should not be at room temperature for more than 2 hours. You should freeze a freshly made blend within 24 hours. You can keep a blend refrigerated for up to 48 hours. And then once you prepare your blend, portion it into containers, label it, and then you want to freeze only up to about 2 months. And then in terms of warming, if you can thaw from frozen in a fridge, that's great if you have that forethought. If not, you can warm it up by putting it in a sink full of cold water and just changing out that cold water every 30 minutes or so. But you really do want to avoid using something like a microwave where the heat distribution is pretty uneven. So planning for one-off, so busy days, travel days, hospital days, emergencies, these things come up whether we would like them to or not. So in an emergency, I always suggest having a backup commercial formula or pre-packaged period items that don't require any blending. I have quite a few patients that do blenderized tube feeds that live in rural communities, and electricity or the power does shut off somewhat regularly. So I always say to have a commercial product in their back pocket just in case, and something that they've tried before. Okay, so we have our fourth poll question here. What is the biggest challenge you face when adapting recommendations for blenderized tube feedings to meet individual nutritional needs? So you should be able to go on the right hand side and vote. Okay, so it looks like we have a fairly even split between, well, a little bit more with limited personnel time and education resources to develop comprehensive and individualized blenderized tube feeding care plans. And then about 22% for A, managing the consistency of the blenderized tube feeding while ensuring the blend meets the nutritional needs of patients, and ensuring proper education training resources for patients and caregivers on the safe preparation and administration of blenderized tube feeds. So, I mean, I think that hits the nail on the head for a lot of the challenges that I face on a daily basis, and I'm sure a lot of you do that use blenderized tube feeds, is those challenges come up, and a lot of them require time on your part and time on the patient and the caregiver's side as well to ensure proper blends. So the last piece is monitoring. So I've broken that down into a few different steps. I know we're getting close to the end of the time here. So accurate prediction of macronutrients and micronutrient content of blend is difficult. We know that. What we can do is we can monitor for hydration status by looking at signs of adequate hydration, so urine output, dry mouth, those sorts of things. And we can monitor weight, anthropometric measurements like muscle and fat mass changes. And that can give us an indication of whether or not they're getting enough hydration and enough calories. And then nutritional blood work may be useful to monitor in patients. Again, depends on the goal of the patient and their needs. So micronutrient deficiencies may arise from continued use of insufficient blenderized tube feeds. There are some standards that suggest baseline blood work and then once every 3 to 12 months. This may be dictated by local policy, but may also just be dictated on an individual level. So, for some people, performing ongoing recipe analysis is a good idea. Again, that's only going to give you a snapshot of that one recipe, but it will at least give you an idea of where they're at. So I've put a couple of examples of professional tools as well as free tools, and then other suggestions like food journaling, 3-day food records, or usual intakes. And that's usually the tool that I lean on, and then I plug into some of those free tools. And that seems to work well for my patient population. But again, encouraging things like alternating ingredients within food groups, selecting foods from different food groups for a complete recipe, and then requesting labs just for those nutrients of concerns is another way to ensure nutritional adequacy. So monitoring GI symptoms, these are a few that I see more commonly: constipation, diarrhea, gas, bloating. All of that to say that it's no different when you're looking at a commercially fed patient versus a home blenderized fed patient. You need to investigate the cause before making any changes to the formula itself. Tube occlusion. So, again, I've called out that it could be due to excessive residue, lumps of food, medications. But really, at the end of the day, what are we educating our clients to do? It's to blend well, flush before and after feeds, and flush before and after medications. Monitoring tube wear and tear. So again, it could be due to things like using oils separate to the blends. It could also be caused by a client using a cleaning tool inside the feeding tubes, which are not recommended. So minimizing the contact time of use of oils within the G tube or blending it up into a blend. Flushing the tube again with before and after feeds with some water, and not using those internal cleaning brushes are ways to reduce tube wear and tear. So foodborne illnesses, so there are multiple studies that show that blenderized tube feeds do contain bacterial contamination when it's compared to commercial formulas, but there doesn't seem to be clear data to show the effects of this contamination on patient outcomes. So again, prevention is key, educating the families on basic food safety, and just emphasizing the importance of preventing foodborne infections as an illness, because they may be misinterpreted as not actually tolerating the blenderized tube feeds. Okay, so that brings me to the end of my presentation. I have a couple of resources that I used certainly at the beginning of my practice when I started to get used to home blenderized tube feeds. So I put those up there for you to see. And as a very last note about commercially prepared blenderized tube feeds, I didn't speak to this in much detail, but we have two available in Canada, one called Liquid Hope and one called Complete Organic Blends. So those are available in Canada, and then there is one called Real Food Blends in the States as well. So there are a couple of them out on the market, and may be a good option as a backup or as a base for home blenderized feeds. So before I finish up, I'm just going to do one last poll question. What are the main benefits you consider when recommending blenderized tube feedings to your patients? Okay, so you can see the results here. Over half of you selected improved patient satisfaction and quality of life. But all of them really are selected, and I think that's the wonderful thing about blenderized tube feeds is there are so many potential advantages to it. What I've seen in my practice with clients who have ALS, so we're looking at more of a palliative end of life approach, this patient satisfaction and improved quality of life is really so key in their care. And that's one of the main reasons why I'm so invested in supporting home blenderized tube beans. Okay, so that's all I have. Thank you for your time. And now I'm going to pass the screen on to Erin.
Thank you, Lisa. I thank you for your presentation. We'll now watch a short recipe demonstration where Lisa shares practical considerations for blenderized tube feeding while demonstrating the preparation of a carrot and pineapple oatmeal blenderized tube feeding recipe.
Hi, welcome to today's home blenderized tube feeding recipe demonstration. My name's Lisa Vardi. I'm a registered dietitian and I'm excited to share with you a recipe called carrot and pineapple oatmeal. Before I get into the recipe, I want to go through the equipment that you'll need in your kitchen. First, you'll need a blender. I have a high-powered blender here today, but you don't necessarily need a powerful blender to make some recipes at home. You'll also need a sieve for this recipe. Here I have a fine mesh sieve, and you likely have something similar to this in your kitchen at home already. There's other sieve options that you can use for home blenderized feeds, and I'll go through them in more detail once we get to blending the recipe. Other than that, you'll need some measuring utensils and a spatula. So now that you have your kitchen set up, we'll take a look at the ingredient list for this recipe. So for the carrot pineapple oatmeal, you'll need 1 carton of either Complete 1.5 or Complete Junior 1.5. You'll need half a cup of instant oatmeal, 1/3 cup of grated carrots, 1/4 cup of pineapple chunks, and 1 teaspoon of ground cinnamon. So now that you have your ingredients all measured out, we can start blending. So the first thing I'm going to add to my blender is the formula. Give your formula a nice shake before you add it to your blender. I like using formula as a base for the recipes because it's a nice nutrient-dense liquid. And it's a good introduction to making home blenderized recipes at home for clients and dietitians who are just getting familiar with making their blends at home. Next, we'll add in the oatmeal. Here I have half a cup of instant oatmeal. I've prepared this according to package instructions, so by making it with hot water. Now, having said that, you can make it with a whole milk or cream or even coconut cream to add some extra calories into the blend without adding extra volume. You'll want to make sure that you prepare any grain the way that the instructions indicate before adding it to the blender. Otherwise, once it's blended up, it will make the blend too thick. Next, I'll add in the fruits and the veggies. So I've got my grated carrots here, and I have canned and already drained pineapple. Fruits and veggies are a great way to add extra fiber, vitamins, and minerals to any blend. The nice thing about fruits and veggies is you can always find them frozen, canned, or fresh. It gives you a lot of different options, and you can easily substitute in carrots or pineapple for any other fruit or vegetable in this recipe. Now the final ingredient is ground cinnamon. Herbs and spices are a nice way to add extra flavor and aroma to your blends. Now some of our clients won't be eating their blends orally, but there are some individuals that will be able to enjoy this at least partially by mouth. The nice thing is these ingredients put together in an overnight oatmeal or a hot oatmeal can be enjoyed by the rest of the family who's eating orally. So now that we have all the ingredients in the blender, we'll get it blended up. So I have a high-powered blender here, so we really only need to blend it for about 1 to 2 minutes. If you had a less powerful blender, you'd probably need to blend it for closer to 5 minutes. So you might notice partway through that some of the ingredients are getting stuck to the side of the blender. What I would do is just pause the blend like I've done, scrape down the sides with a spatula, and then continue to blend for another 20 to 30 seconds until all the ingredients are incorporated. So now that everything's blended together, let's take a look at the consistency. As you can see, it's a nice smooth blend. For a thicker blend that's going through a larger bore feeding tube like a 20 French, or somebody using a syringe method, the consistency closer to about applesauce is probably okay. One way to test to see if the blend is thin enough to go through those larger feeding tubes is by taking an enteral feeding syringe, drawing up some of the blend, and if you can easily draw it up, then you're good to go. Now, for those who are using a larger bore feeding tube and a syringe method, they can use their judgment whether or not they want to use a sieve before administering the feeds. If you're using a smaller bore feeding tube like a 14 French, or if you're using a gravity or pump system, you definitely want to put it through a sieve before administering the feeds. So you have a couple of options for a sieve. This is a fine mesh sieve, and you'll have to pour the blend through and likely use a spatula to push the blend all the way through. It can be a little bit time consuming. There are other sieves available though, such as a flour sifter, that has a blade that can push the blend through a little bit faster. Now, if you're needing to thin out the blend a little bit, you can use any calorie-containing liquid to do so. So you can use something like another box of formula, or even like a whole milk, a cream, or a coconut cream to thin out the blend without diluting the blend too much. You really want it to look like a drinkable yogurt or a thin smoothie. So there you have it, the carrot and pineapple oatmeal recipe. I hope you found this recipe demonstration helpful, and thank you for joining me today.
Okay, we'd like to now start the Q&A section of the webinar today. If you have any questions, you can enter them to the Q&A box, which is to the right of your screen. And we do have quite a few questions already, so let's get at it. Okay, so can you use blenderized tube feedings with a J tube?
Yeah, do you want me to answer that one?
Yeah.
So you can. It's possible, and I know that it does happen. I don't personally have a lot of experience with that just because my patient population almost exclusively has G tubes. The literature doesn't necessarily support it as much as G tubes because it tends to be a smaller feeding tube and it is more difficult to replace if the tube were ever to be occluded. So I know that it's a little bit more discouraged, but it certainly is used, and I think depending on the patient and the case, I think it could certainly be appropriate.
Okay, thank you. There's another question. It's about the consistency. So for the consistency of a blenderized tube feed, do you recommend ITSE level 4 consistency?
Okay, so the ITSE, so I don't have it sitting in front of me, but it really depends on the administration method and the size of the feeding tube. So it's very case dependent. If you're going through the pump, you really want something to be slightly thick, maybe to moderately thick. If there's anything thicker than that, then chances are it's going to inaccurately deliver the feed. So you have to be cautious. It can be thicker though if you're using something like a bolus feeding method. So if you have a bully bag or some sort of reusable bag, or if you have a syringe, you have a lot more wiggle room. Now, having said that, I give the same education to every single client of mine, and they all come back with a different response of what worked for them and what didn't work for them. So I think it also is dependent on what syringe they use, for example, what brand of pump they use, how good their dexterity is, how often they are replacing the equipment. So there's all of those pieces to it too. So it's not necessarily straightforward as this consistency will go through this type of tube with this administration method.
Okay, thank you. And then there was another question about water flushes, pre and post feeding water flushes. What would be the quantity that you would recommend?
So I recommend the same standard minimum of 60 mLs, or if they have a 50 cc, that's fine, before and afterwards. And then I increase depending if they need extra free water. I often tend to lean towards a warm temperature versus a cold, definitely not a hot. I find that it clears out the tube a little bit better. But it would be the same really between commercial and home blenderized.
Okay, thank you. And then just to kind of build on that question, it was about, there's a question about how about how do you, the treatment of, feeding tube blockage. How would you fix that?
Yeah, so I would treat it like, again, like any other blockage. So if you used a commercial formula, or if you had medication that was blocked in the tube, or sometimes we don't know what blocked it in the first place, we would use the same protocols. So I would still start with the warm water and see if that blocks it, and then move down towards the enzymes. And then at some point, if it's not working, then going to emergency or some sort of care for somebody else to unblock it.
Okay,
Yeah.
thank you. And sorry, I was just looking at our time today and we're already over our time. I do apologize. There wasn't as much time for Q&A section today. I did want to thank everyone for their comments and questions today and for participating in the webinar. We do appreciate your feedback. So if you're able to take a few minutes to answer the survey, there to the left of your screen, there's a forms option. And if you click on it, you can complete the feedback survey now. There will also be a feedback survey emailed to you after the webinar. And your certificate of attendance will be emailed tomorrow to everyone who attended today. And then also the recording, once the recording is ready, you'll receive an email that will include a link to the recording and slide from today's webinar. But I would like to thank Theresa and Lisa for sharing with us your insightful information today. We really appreciate you sharing your knowledge with everyone. And we'll end the webinar now, and I hope everyone enjoys the rest of your day, and thank you for joining us today.